time to this webinar. Welcome to the third webinar of Emerging Researchers and Practitioners in Human Factors in Healthcare webinar series conducted by Healthcare Ergonomics Technical Committee of International Ergonomic Association, IEA. My name is Hamid Nourasi, the co-chair of IEA Healthcare Ergonomics Technical Committee. Dr. Sadia Wesley, who is a co-chair of IEA Healthcare Ergonomics Technical Committee, will be helping me today. So today is Friday, February 9th, 2024, and the time is 10:30 USA Central Time. And the goal of this webinar series is to showcase excellent projects in human factors in healthcare done by early career researchers and practitioners known as ECRP across the IEA network. ECRP are PhD students and those who are within 5 years post-PhD, including career interruptions or practitioners who have been working in human factors in healthcare for less than 5 years. The best presenter of the 2023-2024 webinar series will win the Richard Cook Prize. Just a few words about myself. I'm an assistant professor of healthcare systems engineering at the College of Medicine and Science at Mayo Clinic, Rochester, Minnesota. I'm also a research associate at Robert D. and Patricia Eckern Center for the Science of Healthcare Delivery at Mayo Clinic, Rochester, Minnesota, and I have a PhD in industrial engineering, human factors, and economics from Iowa State University. And today we are actually doing a data collection at Mayo Clinic at the operating room. That's why I'm wearing this like white jacket and the surgical like scrubs. Sorry that I'm not wearing like suits and a tie. And our plan for today's presentation, today's webinar, is that the duration of this webinar will be 90 minutes. We will have 5 presentations. Each presentation will take 15 minutes. 12 minutes is for the presentation and 3 minutes is for the Q&A section. And please put your questions in the Q&A section that we have and use the chat for the general questions that you have. The webinar will be recorded, and that's why actually I set the date and the time. And the 12 minutes for the presentation will start after the presenter introduces themselves if they like to do so. If we have time at the end, we will dedicate it to an open Q&A session. And you can ask any question from any of the presenters that we have today. Sadia, before I introduce our first presenter, would you like to say a few words about yourself and today's webinar, if I forgot anything?
It's an absolute pleasure to be here and welcome everybody. We've really enjoyed organizing this webinar, and I am really looking forward to your presentations. We've got some very interesting topics. My name's Dr. Sadia Wesley. I am a research fellow at a Human Factors Research Fellow at the University of Oxford. It's lovely to meet you all.
Thank you. So our first presentation is titled Over-the-Counter OTC Senior Station Co-Design and Usability Testing of a Technological Intervention to Promote Older Adult Medication Safety. Our presenter is Jordan Hill from Indiana University, Bloomington, Indiana, USA. Jordan, the stage is yours.
Great, thank you so much. Can everybody see my slides? Yeah. Perfect. All right. Great. So yeah, my name is Jordan Hill. I have a PhD in industrial engineering with the focus on human factors from Purdue University, and I'm an assistant research scientist at Indiana University School of Public Health in the Department of Health and Wellness Design. And so as mentioned, I'm going to be presenting on some work that I've been doing with quite a large group of people on creating something called OTC Senior Station. So I'll be presenting on the co-design process and usability testing of this intervention, and the goal of it is to promote older adult medication safety. Oh, there we go. So yeah, I might be presenting this, but there's obviously quite a large team, and this whole project is a collaboration between Indiana University, Purdue University, and the University of Wisconsin-Madison, and it is funded through the Indiana CTSI. So to start, I'll just give a brief overview of the problem we're trying to address, because not all of you are likely experts on older adult medication safety. I know I was not when I started. So this project focuses specifically on a type of medications called anticholinergics. And so some really common examples of these are like Benadryl or Dramamine or Unisom, and they make you feel kind of drowsy. So these medications, chronic use of them in older adults is associated with Alzheimer's disease and related dementias. So there is kind of a push to minimize the amount of these medications that older adults use, but most interventions that have been created to target this target prescription medications and not over-the-counter medications, despite the fact that there are a lot of over-the-counter medications that have anticholinergic effects, and they're widespread. Their use is widespread among older adults, and there is kind of a low awareness among this population that these medications may be unsafe because they're over-the-counter, so you kind of just assume that they're okay. So the goal of our research team was to address this kind of gap by creating a consumer-facing information kiosk to promote safe OTC medication decisions. So the goal of this would be to create sort of a consumer-facing information technology, so it's scalable, so you can reach a lot of people. We would want it to be usable by older adults who, as you know, may have very differing comforts with technology. And we want it to be useful, so we want it to address their needs in terms of safe medication decisions. And so for the rest of this presentation, I'll present on the co-design process that we used to design this prototype, and then the lab-based usability testing that we've done on it. So for those of you who are maybe not less familiar with co-design is involving the end users in the design process from the beginning. So the goal is that you don't spend a lot of time creating something that doesn't meet someone's needs or isn't what they actually want or need. So we took this funneling approach to co-design. We did 2 parallel groups of end users. So we had one group of 5 older adults and one group of 4 pharmacy staff, which included pharmacists, 2 pharmacists, a pharmacy tech, and a pharmacy intern. And they each group participated in 5 sessions separately. And so the first session was just introducing them to the problem. The second one, we kind of encouraged them all to get creative, which they actually did get quite creative. And these are some of the designs that participants in our group drew for us. And then session 3 and 4 was creating lower and higher fidelity prototypes to show to the groups to get feedback on. And then session 5 was we brought it all together. And these 2 groups actually created very compatible prototypes separately, mostly because the older adults were focused on what they wanted to see, what information they wanted to be given, and the pharmacy staff were much more focused on the information that the kiosk would need to take in order to give accurate recommendations. So we ended up with a design at the end of the co-design process. And so this is sort of the flow, the general flow of the kiosk. So it has an attract page, and then it allows users to select what they're looking to treat. So for example, allergies. And then it provides a list of different medications. And then depending on which you select, so if you select Claritin, which is not an anticholinergic, it would be marked as safe. And if you picked Benadryl, which isn't anticholinergic, it would be marked as unsafe. Alternatively, the prototype does also have a scanning feature, so you can take a box off the shelf and scan it, and it would lead directly to the senior safe, not senior safe page. So if you just scanned Claritin, it would go straight to the Claritin page. And then there is also a feature to call a remote pharmacist for counseling, which our older adult group really wanted access to. So with this design, we went and took it to, we wanted to see how it was used, how usable it was, and if people, and sort of how it impacted people's medication decisions. So we did a 3-round approach to this lab-based usability testing. We ideally wanted 5 participants in each group, but because of no-shows, we had 4, 5, and 4. This allowed for us to identify some problems and have some redesign in between rounds to hopefully improve the design and then identify further issues with everything as we went. So the general flow of our usability testing was we would sit people in front of the prototype, ask them what their first impressions were. Then we would have them do 3 randomly ordered tasks. So we would ask them to find an allergy medication, a insomnia medication, and a nausea medication. And then we would then ask them afterwards to rate the usability of the kiosk. So there was a significant kiosk and prompt redesign after round 1. So after round 1, we did not have the physical kiosk prepared yet. So what we did was we used just a monitor turned on its side to show the flow. And then we sat people in front of it and had them touch the screen and do kind of a Wizard of Oz touch screen with it. But by the second and third round, we had our physical kiosk prototype, which looks like this. So it had a plywood box. It has a touch screen. It has a scanner. And then you can see our little smorgasbord of drugs on the side, which was our pharmacy. And so additionally, with the first round, all we did was ask the people to choose a medication, and none of them used the kiosk at all. And so for the second and third round, we went on sort of a tiered prompting approach. So we would say, pick a medication, and then if they didn't use the kiosk, find another way. And then if they still didn't, use the kiosk in front of you, and then use the screen in front of you. So we really pushed them to use it so that we could get actual usability information from them. So for kiosk use, this is presenting the results of the 9 participants in rounds 2 and 3, because again, people did not use the kiosk in the first round. And so as you can see in the table on the left, nobody used the kiosk for their first task at the first prompting level. And it required, the prompting levels are the A, medication, B, different way, C, use the kiosk, D, use the screen in front of you. So it did require a quite a bit of prompting to get people to use the kiosk. But when you look at the plot on the right, so this is their initial choice. So they either picked a safe or unsafe medication, or they didn't choose. They said, I would talk to a pharmacist, or I don't know what I would pick. And then aided, so either they used the kiosk to make a safe choice or an unsafe choice, or unaided, meaning they did not use the kiosk. And then at the end, everybody used the kiosk and whether they made a safe or unsafe choice. So only 12 out of the 27 choices were safe initially, although undecided, you could also add was also safe because they didn't pick an unsafe choice. But then at the end, after using the kiosk, 26 out of 27 choices that participants made were safe choices. So it did have quite, these are preliminary results, obviously in small n's, but it looks like very promising that it can really positively influence medication safety choices among people. And then these are the system usability scale scores by test round. Again, round 1 is kind of special because they didn't really use the kiosk. This was all like, okay, like, maybe click this and see this. How do you think this is usable? Whereas round 2 and 3, they actually did use the kiosk to like solve a problem and in a scenario. So, but as you can see, we had acceptable to good usability scores. This was found to be pretty usable by our participants. So in conclusion, as mentioned, the kiosk had acceptable to good usability scores. And then sort of to us after the study, participants did express their support of the kiosk and its purpose. So they said they thought this was really important, and that they liked what we were doing and were hoping that it would, see widespread use. There is evidence that this could be pretty effective at promoting safe decisions, but big caveat there is only when it is used. And so that's sort of the big thing that we're currently trying to address and grapple with, is the fact that it takes a lot to get older adults to use this kiosk. And so we need to figure out how to make that more intuitive, how to work that into their workflow, and how to so that we can scale this. And so our next step is we are working with a community pharmacy to do usability testing in their stores. We're going to experiment with different sort of attract mode designs and different ways to attract people to use the kiosk to try to break through that habit of not using it. And then eventually we are looking to apply for funding to sort of scale this up and test the efficacy and real world implementation of this kiosk. That's the end. And so if you guys have any questions, be happy to address them.
Perfect. Thank you so much, Jordan. It's a really interesting and practical project. So, Sadia, do we have any question in the Q&A section?
We do not have any questions in the Q&A or the chat. So no. Do you have any questions?
Oh, I see a Q&A.
Yeah,
Oh, can you see questions? Oh my God, sorry, I've gone to the answered. I do take this back. No. I was on the wrong section.
Okay, gotcha.
Would you like me to read the question out or?
Yes, please.
No,
That will be
Oh, okay, sorry.
great. Oh,
Yeah.
Jordan, yeah.
Oh, just Ashley Hughes says this is a really interesting and great study on the topic of getting older adults to use the kiosk. Do you think it is a matter of them not knowing about the safety risks, or is it something else? So I don't know if it's that they don't know about the safety risk, because most of the older adults that we talk to are actually aware that just because something is OTC does not necessarily mean that it's safe. I think the issue is that they are not like kiosks. It's not something that is ever really in their workflow at all. It's just a very new thing that they're not. So even when we sit them down and are like, look at this thing, but then we tell them like, you need an allergy medication. They're just like, well, I have allergies. I always take Benadryl, so I would buy Benadryl. And like, I think it's breaking into that habit and into their flow and their workflow. And I think that is the main issue. And that's the big challenge, is that it's getting people to realize, like, no, you need to stop and check the medications that you take. And then this is the thing you can use. And so hopefully it'll be like, with airlines, when they have all of the kiosks now, you don't actually go to like the desk to check into flights anymore. You just go to these little kiosks. So like maybe it'll be like that, but it'll take a while because you have to train everybody to not go to the check-in desk. And then I hope I answered that okay. And then somebody else asked, do they think they could have privacy issues or be embarrassed? So we did ask about that, actually, especially with the the remote pharmacy talking. And people they did not seem concerned about that, actually. So because we asked, are you worried about talking to a pharmacist potentially in the aisle? And they said no, they didn't. Nobody, they were kind of like, not really, or yeah, that didn't seem to be an issue, because that was something we thought that they would be worried about. How are the research? So the other question is, how are the research questions you are trying to address? I assume that you mean like, what are the research questions? So at this current early stage, it's mostly, is there sort of, can we create something usable that that people will use? And then what are sort of the preliminary evidence on how it impacts the safety? But I think in a bigger study that we would seek funding for, it would be sort of those efficacy questions, like not only like, okay, how often is it used? Things like that, but also like, how does it impact the decisions that people make? So does it significantly lower the rate of OTC anticholinergic purchasing? And so obviously we've got to figure out exactly how we measure all that stuff, because this is pretty early stages at this point.
Jordan, we are at 15 minutes,
Yeah,
but
sorry.
I think we have one last question. I think it's okay if you just go ahead and answer that question to like 1 extra minute.
Yeah, thank you for this interesting way to engage older adults in their medication choices. Did the customers need to speak to a pharmacist? Does the kiosk prompt questions about other medicines they use? So no, they do not need to speak to a pharmacist. The option is there if they would like to speak to a remote pharmacist. Generally, actually, I don't think any participants use that feature without us prompting at the end to say, oh, why don't you check this out? What do you think about this? So no, they don't have to. It's just there if they want to. And then it does not prompt questions about other medications. So that is definitely something that, again, if we went, this is purely identifies whether something is an anticholinergic or not an anticholinergic. So obviously there are questions surrounding the complicationness of medications that would need to be addressed in a more mature prototype, but currently it does not do that.
Okay, perfect. Thank you so much, Jordan, again, for your
Thank
great
you.
presentation. There are other questions coming, and I think we can just like keep them for the end of the webinar. If we have that overall like Q&A section at the end, we can answer those questions. Actually, I had a question myself, like about the population, the participants, and like their age, and like were they a good representative of like the elderly community, but we can keep it for the end of the webinar for sure. So let's move forward and go to the next presentation that is titled Reducing Outpatient Falls, Human Factors Informed Fall Risk Assessment Tool Development. Our second presenter is Allison Trees from Johns Hopkins Medicine, Baltimore, Maryland, USA. Allison Trees is a human factors engineering with the Armstrong Institute of Patient Safety and Quality at Johns Hopkins Medicine. She received her Bachelor of Science in Industrial and Systems Engineering and Master of Science in Human Factors and Health Systems Engineering from the University of Wisconsin-Madison. In her current work, Allison used a socio-technical systems approach to address barriers to the delivery of safe patient care. Allison, you can share your screen, and please, if you want to add to my introduction, you can do that. It will not be counted on your 12 minutes, and then after that, you can start your presentation.
Thank you so much, Hamid, and good morning, good afternoon to some. Thank you for this opportunity to present as a part of this webinar series. As mentioned, my name is Allison Dries. I'm a human factors engineer with Johns Hopkins Medicine. And today I'm going to be presenting on our work to reduce outpatient falls through the development of a human factors informed system assessment tool. So we can all level set and get a common understanding of what fall risk factors look like in an outpatient space and what a patient might experience in an outpatient clinic. I'm going to walk through this patient story, and you'll see throughout I've highlighted a couple factors that could contribute to fall risk in red. So we'll walk through Anne's patient journey. Anne is coming to the outpatient clinic today for an eye appointment. Normally at home, she uses a walker, but today she's bringing her cane to her appointment instead because the walker is a bit difficult to fit in the car. Once she arrives, the lobby is very busy. The receptionist did not complete the fall risk questionnaire when she checked in. So unfortunately, they weren't able to capture that Anne actually previously had a fall in her home about a month ago. So Anne proceeded to sit down in the waiting room, waiting for her name to get called for her appointment. When it was time to be roomed, Anne struggled a bit to stand up from her chair in the waiting room because it didn't have any armrests. She couldn't get any leverage to stand up. She then proceeded, once she stood up, to the exam room where there was a bit of a transition in the flooring in the doorway where two different types of flooring connected. So Anne proceeded to have her appointment. By the end of her appointment, she was returning to the lobby. Her eyes were still a little bit dilated, and so her vision was still a bit blurry as she was leaving her appointment. So in this scenario, Anne did not fall, but you could see that there are so many different opportunities for that to happen. The story is also not just a one-off. Falls are a very serious problem, according to the Joint Commission 2023 report. Falls account for the most sentinel events when we consider all types of hospital and clinic spaces. They make up 42% of sentinel events in 2022. And amongst ambulatory or outpatient spaces, they're the second highest sentinel event type, and they make up 22% of falls. Falls are obviously not a new topic. I imagine many of you, if not all of you, have heard about falls before. But obviously there's still a lot of work to do to reconcile each of these risks and reduce the number of falls. Here at Johns Hopkins Medicine, our organization has placed major focus on reconciling risk factors for falls in inpatient hospital spaces, but we recognized a gap and a need to implement that same rigor in addressing falls in our outpatient spaces as well. As you can see, we have a lot of outpatient clinics, and they cater to many, many different specialties. And so as you can imagine, all of these different clinics have their own unique work system characteristics, and as such, also likely have their own fall risk factors that could contribute to a patient fall in that space. As our human factors team, we recognized it may not be feasible or practical for us to go to all 70 of these outpatient facilities and do a human factors assessment proactively to identify the fall risks and reconcile those risks. But we also don't want to wait for a fall to happen and to look at a work system reactively after that. So we are trying to think, how can we still use human factors to support all of our outpatient clinics to mitigate fall risks and do this proactively? So that brings us to the topic of this presentation today. We developed an outpatient fall risk assessment tool. The purpose is for this to be used proactively by frontline staff in these outpatient clinics to assess their work system factors using human factors methodologies to understand what could contribute to falls here and what could we do to rectify this and mitigate falls in the future. To do this, we, of course, understood what others have done in the past. How have other hospitals and clinics reduced their fall risk? But we also did a human factors evaluation in our outpatient spaces as well, so we could understand what are the different work system factors in these spaces that could contribute to fall risk. This, of course, is a great application for human factors, where we understand humans and how they interact with their work systems, and then design the work systems to best fit people. And so with these 70 plus outpatient clinics, all of them may have a different patient population, environment, types of tasks that are carried out, tools and technology available to use. And so we want to ensure that each of these clinics has solutions that are tailored to them to help mitigate falls in that specific work system. So now I'm going to jump into what we did to develop this tool. We went through a few different steps, and I'll go through each of these individually. We used, of course, a human factors framework to guide the development and leveraged learnings from past literature and research as our guiding principles, and then really filled in the meat and potatoes of this tool through our outpatient clinic observations and focus groups. So for the development of this tool, we relied on the SEEPS model to guide our understanding of what makes up a work system, what are all of the different factors that we need to think of when we think of what all could contribute to falls. It's not just the environment, it could also be something related to the tools and technology available, the policies or teamwork, so many different things. And so this is what we started with as we went into our assessment and development of the tool. We also completed a literature survey. We wanted to understand lessons learned from other research that was conducted in inpatient spaces, outpatient spaces, and even non-hospital spaces, just to lay that groundwork of what should we even be looking for that we may not have assumed or thought of off the bat. But the major part of this work was through our observations and our focus group interviews. For observations, we completed a walkthrough at 3 different clinics. Each of these clinics catered to patients with different specialty care needs. And they also were situated in different types of environments, some embedded in hospitals, others standalone building clinics. Through these observations, we walked through the clinic as if we were a patient. We wanted to understand who might the patient interact with, what environments might they interact with, what tools or technologies might be used in their care. So we could capture all of the going to reception, sitting in the waiting area, brought back to an exam, moved to the lab to draw blood, etc. And through that, understand what could contribute to falls in each of these different phases of their journey. We also completed focus group interviews with experts that have a very intimate knowledge of falls. So they included our colleagues in patient safety, risk management, human factors, and learning from our team that focuses on inpatient falls as well. And they helped us validate what we found from observations, but also help bolstered what we found from observations to add on any expertise that they could add. So this is our resulting fall tool. You'll notice our observations helped us develop this patient journey pathway. And this is to help frontline staff consider, we need to look at all of these different phases of the patient journey and consider fall risk, not just in the room, not just in the lobby, all of the different, in the hallway and in the parking lot. The SEEPS model, you can see, helped us define these different categories and sections of our work system. So our environment, our tools and technology, etc., as a framework for how we organized this tool. The lit review helped us understand these categories over here on the left for things that we know have commonly contributed to falls, like flooring or lighting. And then a lot of the more detailed questions that we've embedded in this tool were developed through our focus groups. And so a frontline staff member using this tool would consider each of these different questions at each of these phases of the patient journey and check, like, yes, we've satisfied this criteria, and anywhere that anything hasn't been satisfied is an opportunity for improvement. So developing a tool is all good and well, but we want to make sure that it's actually useful and effective for frontline staff. So we completed a usability survey. We asked frontline staff at our outpatient clinics to use this tool, conduct a fall risk assessment in your clinic, and then fill out this survey to let us know, was the tool easy to learn to use? Could you understand what all of the questions meant? Did it even help you identify something that could be resolved in your clinic? We had 16 different people respond to this survey. They represented a wide variety of roles, including nurses, technicians, clinic supervisors, and other management. And they all represented 15 different clinics within our health system. We can see from this data that most people agreed or strongly agreed that the tool was easy for them to learn. They could understand the questions that they were being asked to walk through. They felt they could do this independently. They didn't need an expert to guide them through it. This last question I'm going to come back to on the next slide, because we can see that there's slightly less agreement about whether they were able to identify meaningful and actionable opportunities to prevent falls in their clinic. We also did ask that staff, if they found something that could be improved in their clinic, to let us know what that was. So there were different ideas related to improving fall risk screening, the lack of equipment available to help patients with ambulating, or opportunities to rearrange or resolve some issues in their walkways. Related to that last graph earlier, we did get some feedback from staff that were like, I used the tool, I found something, but I'm a nurse at this clinic. I don't even know where to go or what to do once I've found something that could be improved. So as an iteration on our tool, we wanted to design a process for submitting anything that could be resolved to ensure that the right people get involved and that something's actually done about it. So we did this through our patient safety event reporting platform.
Alison, sorry,
Yep.
but we are at 12 minutes. If you just try to wrap up, maybe.
Yes. Yeah. So today it's being used as in our root cause analysis information gathering. It's embedded within a couple clinics, and we're continuing to figure out how to embed this into existing assessment forums so that it's proactively and regularly used. That's all. Thank you so much. I'm happy to answer any questions.
Okay, great. So we have like about 2 minutes for the questions. Let's see if we have. And while we are receiving the questions, I'm just like the presenters, if you please write down the questions that we don't have enough time to answer, and at the end, if like you answer those questions, that would be great. Do we have any questions in the Q&A section?
Yes, we have one. So there's a comment, appreciate digital technology. What would the fail-safe mechanisms, I think, be if the patient does not declare all medications or new information about new interactions in new medication?
This question related to this one or the presentation before, maybe?
No, because I think this is the before. No, this is the one before. Sorry, it came through.
No problem.
So you don't have any questions. Do you have any questions, Hamid?
Yes, actually, I have a question. So recently, I've seen many companies and researchers working on the application of AI to predict fall. And when you were doing that project, is it going to be a part of how to predict like falls? And these days everyone is talking about AI, and I was just like curious about that.
Yeah, well, I think a lot of this tool that we developed can go hand in hand with other fall assessment mechanisms. I see a question in the chat or in the Q&A also asking about the Morse scale, and that scale, for example, assesses a patient's characteristics to understand if they themselves are a fall risk. So I think that, in addition to how we can assess our work system for fall risks, would be like the optimal way to do it. If there's things that we can cater to certain patients, perfect. And otherwise, let's consider anything else in the work system that could contribute to falls for any patient.
Yeah, and the approach that you use, do you use it in like hospital? Do you think you can use the same in like other places? Not only for fall, like for other problems, engineering problems that you face?
Yes, yeah. Some of it is likely slightly different, like maybe the cadence or the frequency that patients are seen in outpatient clinics is a little different. And so you have to consider what questions to ask and how would you assess falls for patients who are maybe coming for a 30-minute appointment versus those that might stay in a hospital for a couple days. But that's a part of this work, is trying to understand how to embed that patient characteristic assessment tool to understand, like, is this patient a high fall risk? How can we cater to them as well?
Perfect, thanks. So it seems like we are receiving more questions, but if you just please write down those questions, and if at the end we have time to answer those questions, that will be great. So let's move to the third presentation, that is titled Cognitive Task Analysis for Improving Training in Infection Prevention and Control. We have two great presenters for this presentation: Bradley Weaver from Emory University, Atlanta, Georgia, USA, and also Joel Muma. I hope that I pronounced your name. Sorry if not correctly. Sorry if I didn't pronounce it correctly. Again, from Emory University, Atlanta, Georgia, USA.
Thank you. I'll introduce myself first, and then I'll I'll let Joel introduce himself as well. Hi, my name is Brad. I'm a human factors engineer and researcher, both at Emory University and Emory Healthcare. I got a PhD in human factors from Rice in 2021. And now I'll let Joel introduce himself.
Hi, I'm Joel. I'm also a human factors engineer by training. I got my PhD from Georgia Tech in 2019, but I am faculty in the Division of Infectious Diseases in the Emory University School of Medicine, and I direct the Healthcare Human Factors Lab here.
All right, so today we're talking about a cognitive task analysis that we've done for improving training and infection prevention and control. And what we'll be talking about today is published in BMJ Quality and Safety, or at least a portion of it is. And then we have actually some follow-up work that's quite interesting about the training follow-up. But if you want, you can go to this paper that we published and learn more about what we talked about today, as we can only kind of give a limited amount of information in a presentation. But a bit of background first, healthcare-associated infections, which I'll refer to as HAIs, are very common and harmful in healthcare systems and hospitals, yet they're largely preventable. And a few quick statistics on it to kind of support that statement is 1 in 31 hospitalized patients are affected by a healthcare-associated infection, which contributes to 90,000 deaths per year in the US alone. And up to 70% of these infections are preventable with common infection prevention practices, such as hand hygiene or wearing gloves, things like this. These are, very common things that are recommended. And some additional background, gaps in these IPC practices, these infection control practices, are due to a few different factors, some external, some internal to the healthcare workers. Some external factors, to give an example, the built environment down there at the bottom, you can see the design of a patient's room. Some prior research looked at the location of a hand sanitizer dispenser being close to the patient's bed or by the door where they enter the room. And they found that this actually affected whether healthcare workers sanitize their hands or not when they were supposed to. And of course, this is affected by individual healthcare workers' perceptions and attitudes towards IPC practices, towards the tasks that they're performing. And so there is both external and internal factors working at the same time. And so external factors may be, the design of not only the built environment, but also the supplies, the organizational policies or culture. Internal factors might be a person's knowledge, perceptions, and attitudes. And between these factors and actual behavior is cognition that transform these factors into their positive or negative behaviors. So broadly, we looked in the current study to describe the microcognitive work in the context of IPC and describe how these forms of cognitive work relate to the spread of pathogens during simulated patient care. So we ran a study and we recruited 42 nurses. We had these nurses go through a simulation in which they took care of 2 patient mannequins and completed 4 patient care tasks per patient that we assigned to them. And we broadly performed a cognitive task analysis by measuring their performance, by measuring the amount of pathogens they spread during the simulation. Before the simulation, we put pathogens in very specific locations in the simulation. And at the end, we measured where they spread it to, so we can measure that performance. We connected that with cognition, which we measured through a cued retrospective think aloud. The participants were wearing a GoPro on their head, and so we were able to show them a video from their perspective of the entire simulation, which we used to prompt them to think aloud and tell us what they were thinking about during the simulation. And so we could capture their cognition, their decision making, their monitoring, things of that nature. And so here's an overview of the simulation, a bird's eye view, a couple pictures, and the task involved. So for that first room, or for room 2, which we named Sam, here's a picture that you can see the actual simulation environment. We assigned the nurses that were participants in this simulation 4 tasks to perform on Sam, and that was to insert a Foley catheter, administer meds, collect a stool specimen, and auscultate. 2 of these tasks were co-located close proximity to the pathogen that we put into the environment ourselves and then measured after the fact. So if we insert the Foley catheter, there was a pathogen on the patient's genitalia, and the collected stool specimen, there was pathogen on the stool itself, or in the stool itself. And I should mention that these pathogens were actually harmless to humans. So it was safe for the participants. And then for the other room, room 1, which we named the patient Harry, there was also 4 tasks which corresponded in terms of patient risk and healthcare worker risk. And those 4 tasks were wound care, inserting a peripheral IV, toileting the patient in a bedpan, and inserting a NG tube. And again, 2 of these tasks were kind of co-located with a pathogen that we put into the environment, namely the wound care. We put the pathogen in the wound and in the NG tube. Or actually, I believe it should be toileting the patient because it's stool. And then it's a bird's eye view. You can see that there's various hand sanitizer dispensers at the entries of the room, also a supply room that's outside of the 2 rooms. Oops. So at the end of the simulation, after they were all done, we sampled the different surfaces in the environment to detect where they spread pathogens. So we sampled several different places in each of the rooms, on the nurse and on the WOW, the workstation on wheels. That is the computer that they document that. And there's categorically 4 different types of contamination spread, or certain places that they could spread. And the least egregious, the least bad, was the WOW, the workstation on wheels. And then we also sampled various high-touch surfaces in the room, which is a little bit more bad, a little worse. Then the nurse scrub and hands, and then finally critical sites, that is if they introduced a pathogen into a patient's open wound or into their groin for the patient that had a Foley catheter inserted. So we use this to actually collect data on their performance. And here is the results here. And this is simply the results for pathogen spread. So there's quite a large variation in performance between our 42 nurses. And so we had a couple people actually spread nothing that we could detect, and we had some people that spread quite a bit in quite bad places. This was weighted, the different contaminated sites was weighted based on how bad it was. So the critical site is the worst place you could spread a pathogen to. And so that was weighted the most. And then the least bad place you could spread a pathogen to was the WOW, and so it's weighted the less. And so that resulted in these performance scores, in which we did a tertiary split. We tried to divide as evenly as possible. There were some ties. So the number of people in each group between high performers, medium performers, and low performers wasn't actually the same due to those ties, but they're about the same. So we strive to do a tertiary split there. And then we connected the pathogen spread, that performance, with their Think Aloud data and ran an analysis called multi-block discriminant correspondence analysis, which basically told us for high performers, what did they tend to do more often or less often? And the same for medium performers, what did they do more or less often? And then low performers as well. So in our study, we found that high performers tended to monitor situation for risk more often than the other groups. They mitigated risk by applying rules or reasoning, and they reported less anticipation and planning. And this corresponds pretty well to Benner's model of nursing skill development, which was a theory that's been previously studied, especially the proficient level of nursing skill from Benner's model that says that nurses direct their attention to important changes in the situation, and they're really focused on deciding how to respond. And also anticipation and planning become more automatic at this level of expertise. For medium performers, they really anticipated risk more than the other groups. They planned the workflow according to those anticipated risk. So they were really the planners of the group, and that really came through pretty strongly. This corresponded pretty well to the competent level from Benner's model, which is characterized as nurses managing complexity by limiting unexpected through anticipation and planning, and then following plans actually limits their ability to notice and respond to changes in the situation. So it did get them up to a certain level of performance, that medium level, but it limited them from going beyond that level. And then lastly, the low performers, in our study, they tended to deprioritize IPC That is, they sacrificed infection prevention and control practices like sanitizing their hands or wearing gloves when they should have. They focused really on not touching things as an approach to infection prevention and control, as opposed to the other infection prevention and control practices like sanitizing your hands, wearing gloves, cleaning surfaces, things of that nature. And lastly, they tended to follow informal rules as ways to make decisions. And this doesn't have necessarily a great parallel from Benner's model. And as far as implications, I'll go ahead and hand it over to Joel to talk a bit about that.
So as Brad just described what characterize low performers, they seem to have a belief system that puts a low priority on IPC and also seems to focus on trying to avoid spreading contamination largely by tracking what you're touching. And that's a very difficult strategy for practicing IPC effectively in practice. So one implication this has for how we train or approach training low performers is that, first of all, we need to challenge that belief system. And one of the things that makes becoming skilled in IPC difficult is that you're fighting a battle against invisible pathogens, invisible germs. So it's very hard to get the kind of feedback you need to tell you about whether your behavior is having a positive or negative impact on patient care. So here we're recommending that low performers would benefit particularly from having visual feedback to show them just how easy it is to transfer germs by touch and how that's not an effective approach to practicing IPC. For medium performers, however, they are competent at practicing IPC. They understand the function, the usefulness of these different practices, but what they seem to have the most difficulty with is integrating that understanding, that knowledge fluidly into patient care. And we say that because, again, these were the groups that would deliberately and effortfully try to anticipate what's going to happen when I walk into that room. What risks am I going to encounter? How can I plan and engineer my workflow so I can minimize cross-contamination, which are clearly beneficial practices. But the problem here is that you can't get by on planning alone in patient care, given the nature of things like interruptions, which we did incorporate into the simulations. So here the recommendation is more that medium performers, to improve their performance, would benefit more from getting opportunities to practice applying their knowledge during patient care in levels of increasing challenge or complexity. Next, Brad. So what we've taken from that is we need to provide training that's able to give people immediate diagnostic feedback about how their behavior plays a role in the movement of pathogens, particularly helpful for low performers. And at the same time, we also need to give people the opportunity to apply their knowledge in realistic, challenging patient scenarios. Next slide. So we went from high fidelity simulations to virtual reality, in large part because we can get both the complexities of patient care recreated, and we can give people immediate feedback on how pathogens transfer, which we couldn't do in high fidelity simulation. Next slide.
Dr.
So just
sorry, we are at 12 minutes, so if you wrap up your presentation, that would be great. Thanks.
Yeah. So we've designed a virtual reality training application where people can visualize the transfer of germs in real time, so they get the feedback that they need. Next slide. And also we've created these levels of increasing complexity where tasks become more complex, interruptions become more challenging. So that way we're accommodating and able to target the training gaps that low performers suffer from in medium performers. And we're currently piloting this on units at our hospital as we speak. And that's the end there.
Perfect. Thank you so much. This is amazing. This is a great project with a lot of applications. And thank you. Great. Thank you so much. So do we have any questions, Celia?
Yes, I'll try to get it correct this time.
Okay.
So we've got a excellent presentation, by the way, guys. So we have a question from Catherine Gaddy. So were low performers less experienced across the board? Did you find that at all?
We asked how long when did they receive their first license for nursing, and we analyzed whether that was correlated with their performance group, and we did not find that was the case. So the short answer, no.
Thank you very much. We do not have any more questions regarding this fantastic presentation. However, if you do, you are more welcome to refer to the presentation and we can answer it throughout.
Okay,
Thank
I
you
have
very
one
much.
more question
Oh.
actually. So what about the effects of fatigue? I mean, either mental and physical fatigue. And is there a way to consider that in your simulation, or is it something to just with your participants to consider that mental and physical fatigue?
Yeah, so it's people tended to participate off shift. But that is something that could be incorporated into simulation where, we schedule these simulations to happen at a point where you are fatigued. And yeah, I think those things definitely play a role in how you practice. And our interest is in, given those kinds of demands that are put on people, how are people able to effectively perform patient care for better or for worse? Like we designed this simulation to be challenging, and we found that, despite having a challenging simulation, people approached it differently, and their cognitive approach made an impact on their performance. So we're trying to understand why is that.
Perfect, thank you. So let's move forward. Our fourth presentation is Designing Atypical Working Hours, a participatory multi-stakeholder approach in a hospital environment. Our presenter is Marlene Chairos from Université of Montreal, Canada.
Do you see my screen?
Yes.
Okay. Hi everyone, my name is Marlene Chairos. I'm French, so I hope you will understand my accent. Sorry for that. I have a PhD in ergonomics. I did my thesis with Béatrice Barthes at the University of Toulouse in France. And the study I'm about to present is part of my thesis on hospital work with atypical working hours. I did my thesis in a private clinic in France. And this clinic wanted to design innovative schedules. So the organization of working time is actually recognized as a social innovation for its positive effect on living conditions. But social innovations, social innovations can also be found in the way solutions are built, are constructed, but it needs some conditions. First, the actors concerned must participate in the choice of these solutions to appropriate these solutions. And secondly, their logics have to be different to build a common representations of issues and solutions. And in activity ergonomics, the organizations of working time must be associated with a reflection about the work contents, and the solutions must be discussed with all the actors of the situations to choose the best compromise. So the organization of working time is a delicate process because temporalities of schedules are interdependent with temporalities of the work and temporalities of the workers. Indeed, only one change of schedules can upset their balance and produce potential negative effects. The organization of working time can be innovative if it's associated with an interprofessional discussions about the work's contents, and the work simulations methodology can both support the design of new schedules and the interprofessional discussions of work content. So the first objective is to show that issues related to schedules and work content are interdependent. The design of schedules can't be achieved without improving work content. The second objective is to show that the design of new schedules is an opportunity to rally the actors of their different professional logics in a discussions on work content. These interprofessional discussions, aided by simulations methodology, allows the planning of future working conditions, but also underscores current working conditions. And the third objective is to show that these interprofessional discussions can facilitate the appropriations of solutions. I'm going to talk about methodology. So my thesis took place in a pulmonology unit where caregivers worked in 12-hour shifts. So one night team and one day team. The first year was devoted to an inventory of the initial work situation. So I observed the work of caregivers, of physicians, day managers, and administrators. I observed the durations of nurses' oral transmissions. I observed the patient discharge schedules. And finally, I asked to the caregivers and to the physicians what was their representations of the work situations in some interviews. The second year was devoted to the design of and to the projection of solutions. So the different professional logics of the units have been gathered in 3 groups using different simulations models. Actually, there are more groups, but I want to talk about 3 groups today. I built my analysis protocol using Actograph software. And for each group, I recorded the distributions of speaking time by professional logic and by purpose. I also noted every time the participant faced one constraint of their work, and every time they verbalized one condition for the success of a solution. The third year, the last one, was devoted to testing the new schedules and evaluating the group's effects. So new schedules were tested for 3 months in the unit, and during this testing period, I observed the organizations of patient discharges. I retrieved the discharge schedules of all patients registered in the hospitals in the pulmonology unit. This enabled me to make a comparison between the test period and the same period from the previous year. And finally, I asked to the caregivers about their perceptions of the new work situation. So now I'm going to talk about some results. The inventory of the initial situation revealed one issue in schedules. Actually, nurses, so day nurses and night nurses, arrived earlier and left later to extend the official day-night overlap dedicated to oral transmissions. It was necessary to extend officially this overlap by moving the day nurse shift forward 15 minutes. This temporal change was difficult because of 2 issues identified in the work content. The first issue was related to the patient's flow in the pulmonology unit. In fact, incoming patients were placed late in beds because these beds were freed up late by outgoing patients. The second issue inside the unit was related to the physician's coordination. The times at which they identified outgoing patients and formulated new prescriptions were totally unpredictable. And without a joint improvement of these 2 issues, the new nursing schedules were impossible. In the three groups analyzed, several constraints were verbalized. According to physicians, it's an example, but according to physicians, the digital incompatibility between their dictaphones and infirmaries terminals delays the transfer of dictated prescriptions to the secretaries. According to the secretaries, the late transfer of dictated prescriptions delays writing and sending these prescriptions to nurses. And finally, according to nurses, late transfer of writing prescriptions delays the patient's discharge. In order to make outgoing patients leave earlier, to bring forward the installations of the incoming patients, and to bring forward the end of the day nurse shift, several conditions were verbalized. Outgoing patients must be identified by physicians the day before. Prescriptions must be dictated with a dictaphone by physicians the day before, and nurses must call physicians to notify them of incoming patients' arrival. Regarding the testing of the new schedules, all the nurses said that the extensions of the day-night overlap allowed to recognize the extra work time they invested, but it was not official. Regarding the patient flow, the comparison between the test year and the previous year shows that outgoing patients left earlier in the afternoon. The majority of caregivers said that patient discharges were better anticipated in the coordinations of the physicians. Firstly, physicians identified more outgoing patients the day before. Secondly, physicians dictated more prescriptions the day before, which allowed secretaries to write and to send it earlier to the nurses. According to caregivers, the interprofessional groups made it possible to open a dialogue with the physicians and to become aware of their real difficulties. And for example, just after Group A, nurses started to call physicians to notify them of incoming patients' arrival. So my results confirm that temporal issues of a work situation, which are always related to work schedules and work contents, are interdependent. Indeed, the extensions of the day-night overlap could not have been tested without a joint improvement in patients' flow and physicians' coordination. Using work simulation as a methodology, as a tool, interprofessional discussions made it possible to identify the conditions that will determine the success of the new schedules. The example of discharge prescriptions dictated by physicians, written by secretaries, and then retrieved by nurses shows the necessary coordination between all hospital work temporalities. The participants used these opportunities to discuss current working conditions, giving visibility to each other constraints. By bringing together a diversity of professional logics, interprofessional discussions have created a cooperation between actors from the care unit. And finally, the interprofessional discussions also enable the actors to appropriate the conditions that they had verbalized in these groups. In fact, most of these conditions became a reality in the unit during the test of the new schedules. So thank you for your attentions.
Perfect. Thank you so much, Marlene. It was really interesting, and you just finished at 12 minutes. It was so on time. Do we have any questions, Stadia?
So I'm looking and I can't seem to see. No, we do not have any questions for this
Okay.
fantastic presentation.
I can
Thank you.
start with a question, Marlene. So you had some suggestions like changing kind of like workflow and even changing schedules like that 15 minutes like ahead or late, what do you think about the implementation when you get to the implementation practically? What would be the challenges? Have you tried to implement them in real life? You know what I mean? Because here at Mayo Clinic, we are working on different like interventions, mostly for physical ergonomics. And sometimes we have great, results from this study, but when it gets to the implementation phase and just to convince people that it is good for you, and just to use that, sometimes it's a bit challenging and it's a research area itself. The implementation and the change management.
Yeah, you're right. It's a big challenge because first of all, you have to go to convince everyone, but that's the role of these groups. It's an engagement because they discussed in all these groups. They decided together to test. Okay, let's do it. Let's test it for 3 months. But you're right. For the success of this test period, you have to give the informations to for example, when you have a new nurses who doesn't know there is a test inside the unit, so I have to find his contact or a contact and say to her, hey, hello, I'm Marlene, I'm ergonomist, and by the way, we are testing a new schedule, so could you be in the unit at this time, because so you have to send some emails, you have to discuss with the directions of a clinic, of course, because it's only 15 minutes, but it's huge for the organizations.
Yeah, exactly. Do you have a question, Celia?
So we don't have any more questions regarding the presentation, but we have a side question about any certificates or confirmations for the attendance for this webinar.
For attendance for the webinar?
No, we don't. We
No,
don't do.
we don't have, no.
No. I'm afraid not. Sorry, Melody.
Yeah.
Okie dokes. I think we're done with questions.
Okay, so if we don't have any questions, let's
Oh,
move forward. Okay.
just got a comment. But we can move forward. So it's a great
Perfect.
solution. Only problem is the nurses have to work on times. Thank you.
Okay, great. So the last but not the least, our fifth presentation is titled Quantifying the Impact of Healthcare System Design on Nurse Workload and Quality of Care Using Process Simulation and Digital Human Modeling. And it says better work, better care. Dr. Sadim Qureshi is the presenter. He works in Human Factors Engineering Lab from Toronto Metropolitan University, Toronto, Canada. Dr. Sadim M. Qureshi is a postdoctoral fellow in the Human Factors Engineering Lab at Toronto Metropolitan University, formerly known as Ryerson University. He is a certified professional ergonomist, and his research focuses on developing human-focused simulation models to proactively test and quantify the impact of different work policies and operational design on healthcare professional workload and quality of care. Dr. Qureshi is also the co-chair of the Early Career Researcher and Professional Subcommittee at IEA.
Thank you so much, Dr. Narasi, for that great introduction. Good morning, good afternoon, good evening, good night to everybody globally. First of all, thank you so much to the IATC of Healthcare Ergonomics for organizing this webinar series that's supporting the early career researchers and professionals. And of course, thank you to everybody that kind of came in and to support us early career researchers. So thank you very much for that. Okay, I know we're a bit pressed for time, so I'll just dive right into it. All right. Okay. Oops. Okay. So it doesn't matter where you're living. All right. We know that the healthcare industry is under immense amount of pressure globally. As you can see, in the past couple of years, millions and millions of dollars have been spent on overtime, millions and millions of dollars have been spent on absenteeism, and about 71% of the nurses that were interviewed here in Canada, they said, well, we're experiencing a burnout and we're thinking about leaving the industry. The International Council of Nurses is actually predicting a shortfall of 13 million nurses by the year 2030. Now, retention is a big problem, and nurses are leaving the profession, but that is one side of the problem. The other side of the problem is, even if we do get newer healthcare providers, such as nurses, how can we make sure that they don't leave the profession? Because the underlying problem, the root cause of the problem is immense amount of workload, work demands, and which is just not safe. So what are we doing about it? So the objective for our study is that we want to develop this proactive simulation model targeted at nurses to quantify the impacts of different technical design and operational policies in terms of workload and quality of care. And today, as an example, we're going to show you what were some of the pandemic impacts. So it is basically the development of a proactive simulation tool. Okay, so we're using discrete event simulation, which is basically an operations research tool heavily used in aerospace, auto manufacturing settings, and even in healthcare. So what is the novelty of this research? Well, we're modeling from the perspective of a nurse. If you're using a human factors lens, I know in the past some models have existed, but they've modeled patient care as a product in a production system. We, on the other hand, what we're doing is we're modeling the process of care delivery for nurses. And as a result, we're now able to really tap into what are the implications are going to be on nurse workload and care quality. Anyways, I'm going to dive right into the model inputs. So we didn't create the model out of thin air. We took anonymized patient care data for 1 year from a downtown hospital in Toronto. We also went to the same unit with our laser pointer, measured the entire unit, created this virtual layout in a software called Visio, and then attached it in our simulation model, which we created using Arena. We also talked to several nurses, found out what the walking patterns were for delivering care, like how would they go about their day. We also found out the care delivery logic, which was deliver the highest priority task at the shortest distance. And we also looked into quantifying the physical workload, the biomechanical workload for nurses. How did we do that? We recruited a nurse for about 12 hours, and we asked them, hey, can you show us every posture that the nurse would have to do every task in the nursing field? It was a very long study for sure, but we were able to quantify all the different biomechanical loads for all the nursing care tasks. So we programmed that as well in our simulation model, and as a result, we're now able to quantify nurse workload and care quality. Now, I know nurse workload is quite a big term, so how we are operationalizing nurse workload. We're quantifying the total distance a nurse has to walk throughout the shift. We are also quantifying mental workload. The way we are operationalizing mental workload is the stack of care tasks the nurse has to do at any given time of the day. We're also quantifying the movement, direct care time, the time that they actually spend delivering care. We also quantified peak and cumulative biomechanical loads, specifically for L4, L5 lumbar load. For care quality, because we all obviously have to take a look into workload and quality of care, we quantified the average time a task had to wait before it could be performed. We also quantified missed care, which is basically care that was not delivered by the end of the shift, and so on. So let me just show you how the simulation model kind of works. This is the layout of our unit. And for instance, the first task comes in, insertion of entity cube. So we have the simulated nurse who walks from the nursing station down to the medication room, and from the medication room goes to the linen cart to grab the linens, goes to the clean room to grab the clean utilities, now goes over to the single bed area, delivers the care, come back to the dirty utility room to drop out dirty utilities, and of course, come back to the nursing station and see what is the next care task that they would have to do. So essentially, this is how the simulation model kind of works. Okay, I'll dive into the results now. So our first experiment that we did, we were able to quantify the time utilization for nurses. Now, these results are pre-pandemic, but I wanted to show you that even pre-pandemic, nurses were overworked. They had 14 hours of work to do in a 12-hour shift. And this is without breaks, by the way. So, of course, if you do add that 1 hour break in the two experiments that we see, 12 hours with breaks and without breaks. So if we do add the breaks, then, of course, the shift work does increase. The utility that we're getting from the simulation model is we can now see how the nurses are spending their time throughout the shift. We get a breakdown of not only the task sequence, but the cumulative time as well. We also, I know I talked about biomechanical workloads for that matter. I will show you what we were able to get. Because we had the task sequence from our discrete event simulation model, we also got the biomechanical workload from digital human modeling techniques. We combined both those techniques, we integrated both those techniques, and now we were able to get a time trace of biomechanical load. So for instance, at 8 o'clock, the first task was, let's say, assessments. Then the second task was, for instance, checking vital signs. The third or fourth task was, let's say, nutrition for that matter. So we not only had the sequence, but we also had the biomechanical workload that kind of came along with this. Okay, all right, now I'm sure a lot of you are thinking that, all right, this is an interesting study, but what about validation? Have you validated this model or not? Yes, we were able to validate this model. We did several tests, but one of those tests that I'm going to talk about today is a step counter study. So what we did was we recruited about 10 nurses in a unit, and we asked them to wear a Fitbit for the 12-hour duration, and we quantified how many steps did they walk at the end of the shift. We also took into account the different patient bed assignments that they got and the different acuity levels as well. We did focus groups to find out the care delivery logics. So what we did was we tested two care delivery logics as well. One group was a lot more experienced than the other one. So anyways, at the end of the day, we were able to validate this indicator by doing inter-class correlation, which showed 97% consistency between our groups for that matter. So anyways, up till now, life was good for us. We were happy. And then all of a sudden, COVID-19 came in, unfortunately. And when COVID came in, we all know the whole world got flipped upside down, especially the world of healthcare. So we thought to ourselves, what could we do about it? We had the simulation model that can actually test and quantify the impact of operational decisions. So we thought, let's maybe test it out under COVID-19 conditions. So what we did was we did a study in which, and of course, I want to first point out, our nurse-patient ratio for that unit was 1:5. We compared our simulation, well, we adapted our simulation model to COVID-19 designated unit, and then we tested 5 different conditions. So we got 1 COVID positive patient with 4 COVID negative patients, 2 COVID positive patients and 3 COVID negative patients, and so on and so forth. So in doing so, we were able to sort of see how the workload of the nurses actually changes throughout. Now, I know this figure looks a little bit busy, so I'll show you, I'll talk to it a little bit. So the blue bars that you can see, they represent the direct care time. Now, as you can see, when the nurses were assigned to more COVID positive patients, their direct care time actually decreased. So what were they doing throughout the 12-hour shift? The orange bars represent the IPAC time, the infection prevention and control time. In simple terms, it was the time that nurses spent donning and doffing PPE. So as you could see, when nurses were assigned to more COVID positive patients, the new operation policy was that you have to don and doff PPE, which is you got to wear your safety mask, your safety goggles, you got to wear safety gown and booties as well. So of course, now for the most extreme conditions, nurses were actually spending upwards of 6 hours donning and doffing PPE out of a 12-hour shift. So if there's so much work demands that are also increasing because it's a COVID-19, a COVID positive patient. So of course, miscare would also go up. So as you can see in this figure, this red line kind of represents the miscare, the total number of tasks that were actually getting missed. So it really kind of gives us a holistic picture of how when you insert a new operational policy, what could be the impact about that, and so on. And again, this picture kind of shows the same thing for donning and doffing PPE and the total tasks that were there. What we also did was we tested our simulation model on biomechanical workload. And this is where we got one of those aha moments. The aha moments that we got was that when nurses were assigned to more COVID positive patients, their biomechanical workload went down, their cumulative biomechanical workload. When we ran these tests initially, we thought that, okay, no, something's wrong. We double checked our results. No, and the results were fine. So why did the biomechanical workload for nurses actually decrease? Well, the reason is that the biomechanical workload for direct care tasks is a lot more than simple donning and doffing PPE, which is your IPAC routines. So of course, if the nurses are now donning and doffing PPE for about 6 hours total in a 12-hour shift, of course, their biomechanical workload will come down in comparison to the pre-pandemic biomechanical workload. Now, of course, this was one sort of positive thing that happened, but of course, there's so many other worse things that kind of happened alongside COVID-19. One of those were mental workload. So maybe 2 steps back, the way we're operationalizing mental workload is the stack of tasks nurses have to do at any point of the shift. So we again tested COVID positive patients and COVID negative patients assignment. So what we saw was when nurses were assigned to more COVID positive patients, their mental workload increased drastically. And donning and doffing was a big factor because the nurses had, anytime they're going into their patient room or coming out, they have to don and doff PPE for that matter. So their mental workload was just continuously increasing. Now I know we're only measuring the mental workload as a task, the number of tasks in queue. One of the study limitations is that we didn't measure the mental workload inside each task. But if we were to add that, we can just see this that the nurses who are already mental overworked, they're going to be even more overworked for that matter. And this really kind of shows that when you do add newer operational policies without testing them, the system can really collapse. I'll take a page out of my mentor's book, and like he often says that, hey, if we introduce newer policies in the automotive manufacturing sector, then no car would ever be made completely. We'll have brakes, we have turn signals missing when these cars are made. But unfortunately, when it comes to healthcare, for some odd reason, these policies are not fully tested before they're actually implemented. And this simulation model that we just developed has the ability to proactively quantify the impacts of newer operational policies and technical design for that matter. So this simulation.
Dr. Gorish, sorry, we are at 12 minutes. Actually, it's like 13 minutes. So if you wrap up your presentation, that will be great.
Yeah, absolutely. My apologies. So just wrapping up. So yeah, this model kind of serves as an engine for improving quality of care and better managing workload. You cannot improve what you cannot measure, right? So this simulation model can actually quantify workload for that matter and its implications. So anyways, thank you very much for joining us today. And these are some of our funding partners. And this is the glorious team that was sort of behind the work I talked about. So I welcome any and all questions.
Perfect. Thank you so much. And thank you for being that energetic in like your presentation. I really enjoyed it.
Yep, that was very energetic. Thank you so much, Sadeem. I don't think we have any questions for your great presentation. They might come in. Oh, thank you.
Oh, I was just gonna say I have a question if there aren't any in the chat.
Yeah,
amazing. Sure. Yeah.
Yeah, so yeah, this was really interesting. I'm not a simulation person, so this is all like very cool and magic to me. But so it seems like you said that one of the ways, like that you quantified mental workload in terms of tasks remaining. And so maybe I missed it, but like, did you really capture as well, like just sort of some of the stress in your simulation? Because I know, especially during COVID, a lot of the, and having family that works in healthcare, is that a lot of it was just like the stress of like COVID and like the danger of like being on the front lines. And then like some of, the abuse that sometimes nurses face or caregivers faced it with like, some of the rhetoric surrounding that. So I was just wondering if any of that was reflected in your simulation at all, because that seems like another pretty significant source of burnout and people not wanting to enter the profession or wanting to leave the profession.
Thank you for that question, Jordan. You're absolutely right. Like, it is a very important indicator, but unfortunately, this was one of the externalities that we were not able to model. Yes, we only quantified mental workload as a stack of tasks the nurse had to do. We were not able to quantify the mental workload inside each task, and of course, we were not able to quantify the mental burden that the nurses had for missing care tasks, because nurses are very resilient people. They want to do a good job, and because they're so overworked and they're just rushing to do tasks and they're not able to fully complete their job, so that also causes severe mental burden and trauma at times. So yeah, that is certainly an extension that we're looking to do. But we know for a fact that even just we look at the stack of tasks, nurses are already overworked, overburdened. So when we do add that indicator, I'm guessing an already overworked nurse is going to be even more overworked for that.
Okay, perfect. Thank you so much. So
No
for
more
Stephanie,
questions. Oh,
perfect. I think there is one or
it is a thank you.
okay,
I don't know
great.
whether you wanted to go back to the questions that were not addressed.
So
Um,
unfortunately, I don't think we have time for like that
Yeah.
general QA section. So I want to thank all the presenters again for the great presentations and for the great work, and also for you all that accompanied us today. And I think it was a great webinar. Thank you all again. And just before closing this webinar, I want to say that our next webinar will be at around May 2024. So be ready for our next flyer with more details about the next webinar. Thank you so much again, and have a great morning, evening, day, night. Have a great time.